So this is also interesting case, particularly clinically, if patient is double one, because acute macular infarction and pure macular infarction with the concomitant stroke in the young patient. So next slide, next one. So therefore, why it is double? What is the double one? The cardiocerebral infarction, a term introduced by Ahmad 2010, was used to describe the simultaneous occurrence of the stroke as well as the acute macular infarction. A definition of cardiocerebral infarction syndrome can be defined as primary disorder that means infarction or complication of one of these two organs, heart or brain, often result in secondary infarction or injury to others or both the organ. Next one. So therefore, so these cerebral infarct and these cardiocerebral, the three type. If you type 1, my case is type 1 because simultaneous acute stroke as well as the macular infarction. And type 2, you see acute ischemic stroke and recent macular infarction. Type 3, recent ischemic stroke and acute macular infarction. My case is the type 1, simultaneous macular infarction as well as the ischemic stroke. Next one. So therefore, my case is that 26-year male is 110 kg weight, heavy smoker, alcoholic, presented with acute heavy paresis of left side of the body, and simultaneously he got the acute chest pain. And ECG shows SC segment elevation beyond to ECG, TROP2 strongly positive, echo 36% hypokinesia of the anterior wall, and on the emergency basis during the admission, CT angio as well as MRI done by the neurologist on call, and the particular the CT, both this, that is imaging shows infarct on the right cerebral artery, and particularly MR shows that is infarct, and particularly thrombus is seen in the ocular branch of inferior division of right middle cerebral artery within 3 hours of hospital admission. Homocysteine level normal, protein A and C normal, vitamin C only 9, vitamin D only 9. COVID test, because it is done on the COVID test, that is 2000, early part of the 2001, that when COVID situation is there, so therefore we repeated 3 times RT-PCR done, it was negative. Echo also done 2nd time, no evidence of valvular disease and aortic dissection or any source of the embolism from any chamber of the heart. Next one. So therefore what is going to plan? So thrombosis is a basic attempt to treat both anterior wall macular infarction as well as the stroke. Therefore, as per neurologist suggestion, and they use the particularly 0.9 milligram per kg of the body weight of RT-PCR is given, and 10% given within 1 minute, and remaining 80 milligram given over 1 hour. After thrombolysis, neurological signs, symptoms drastically improve. Chest pain risk of persistent. So after, because of paralysis improved, therefore I waited for 6 hours. Then I do the angio, which shows the large thrombus from LAD ostium to the D1. Next one. So therefore, my plan for proceed for the angioplasty, and angio shows the white appearance of the proximal part of the LAD up to D1 from ostium. Next one. So initially lesion crossed with cyan blue, while advancing the optic cross then means I was catheter till the resistance, hence the lesion was pre-dilated, slowly the 1.5 into 10 size in the semi-compliant balloon, only low pressure, 8 atmosphere pressure, just to prevent this loss of the clot. Next one. So after that, therefore I was taken, I was shows the thrombus from the D2 to up to the ostium of the whole LAD. Next one. Therefore, particularly the distal zone, particularly MLA was 2.4 only, and thrombus was 35%. Mid zone sorry, the mid zone was 2.4 MLA and the thrombus size 65. Distal zone, the MLA was very reasonable, 6.4 and thrombus 35, and the particularly proximal zone thrombus about 19%, MLA was 8.9. Next one. Next, please. Therefore, based on the IVAS finding, we take a decision to place the DSA 3.5 into 38 deployed because of huge thrombus. I taken the synergy, which I think will be better with thrombus resistance. So ultimately, after pre-dilation, the stent is placed from the ostium to the D2. Next one. The postal IVAS shows that the stent is fully opposed, satisfactory expansion of the stent and no edge dissection, no dislodgement, any clot or any tissue protrusion. Next one. Therefore, the angioplasty, it was there is a critical lesion MLA was 2.8, post dilatation 7.30, and the ostium it is reasonably 8.9 luminal size. Next, great improvement there. Finally, the TB3 flow and patient discharge after 72 hours of the observation. Next one. My question: what is the reason for simultaneous infarction of the brain as well as the MI? Next, please. Yes. First mechanism that the apical infarction in cases of present anterior marking infarction and LV systole function provides a substrate for the thrombus formation, which prompt to increase the embolization both coronary and cerebral artery. Second explanation, embolization of the coronary or cerebral artery have been reported due to atrial fibrillation because of possibility of the paradoxal embolism of the right thrombus or deep vein thrombosis through the patent from an oval. Next one. The occurrence of sudden hemodynamic compromised patient or acute infarction, and particularly in the hypertensive patient, there are also a reduction of cerebral blood flow to water-sac areas of brain and subsequent infarction, and especially if there is some failure of blood pressure autoregulatory system. Fourth mechanism is extension of ascending aorta dissection. If the ascending aorta dissection, type 1 dissection, where the coronary ostium may be involved, simultaneous extension may involve to the carotid artery and vertebral artery, basal artery, which may explain the simultaneous occurrence of the cerebral artery as well as the coronary infarction. So, in my case, there is no evidence of dissection, particularly from the echo as well as angiography. Next one. And other mechanism, when there are insular damage of the brain thought to impair sympathetic vagal imbalance, resulting in the cardiac arrhythmias and wall muscle abnormality who develop the clot in the ventricle as well. And sixth mechanism, adrenergic shock may result from catecholamine-induced myocardial infarction, stanning, common cause of the stress-induced cardiomyopathy, that is Takotsubo, which may miming like ST segment elevation, in turn provide for formation of intercardiac thrombus, may embolize to the distal cerebral and coronary artery. Next one. So these are the six mechanisms. In my case, most likely I believe from embolus from the left ventricle. Regarding the management, there are also controversy because the incidence of the disease is very rare. That is 0.009%. So therefore, there is no guideline, there is no artificial study, there is no study at all. So treatment management individualized. In this patient, management protocol may be antiplatelet therapy, GP2B3 inhibitor, anticoagulant used for coronary intervention, presence of myocardial infarction, which increase the risk of hemorrhagic conversion of stroke with thrombolytic therapy. One problem. Second, use of thrombolytic therapy, acute stroke, also increase the cardiac wall thinning and also cardiac rupture and cardiac tamponade. Second problem, intravenous thrombolysis approved particularly acute management of both the condition has suggested as the best approach to treatment of simultaneous, that is the CC, then mean market infarction as well as cardiac stroke. Of course, if there is no contraindication. Next one. Yes, the American Stroke Association recommended 0.9 milligram per kg of the per kg of tendency place. Particularly here the 90 milligram as per selection LT place, and 10% of this total dose is given over 1 minute and remaining part given over 3 hours. Next one. So therefore, the combined endovascular approach with the use of PT shape for MI and thrombectomy device for the particular stroke has been suggested. But my center, though the endovascular team is not strong, so at a time when doing the angioplasty, the chance, ideally I think thrombectomy to be done followed by the angioplasty, ideally to be done. But in this case, we have done the thrombolytic therapy, particularly with the use of LT place, so you have used. Next one. So conclusion, particularly because I believe this patient, 26-year-old, overweight, concomitant MI and strokes, which reached the hospital within 3 hours, managed by thrombolytic therapy followed by the PTC, that means pharmacoinvasive therapy. During the hospital stay, dramatic improvement in neurological manifestation indicating some embolic phenomena of the brain most likely. The nearest 2 years follow-up, ejection fraction improved 36 to 60%. Patient, young patient, and body weight now reduced to 80 kg by lifestyle modification, and he also continues regular medical therapy. He is doing well. So this is the message from my end. Therefore, so in our study, the incidence is very low, 0.009 % incidence of the simultaneous market infarction as well as the cardiac thrombosis. I think in our country, better to use the thrombolytic therapy at a time if the patient reach within the window period, both MI as well as for the acute stroke. Thank you very much indeed.
Thank you, sir, for the very interesting case.
Yes.
I got one question for you, sir. Now, you did you did imaging, and you said, of course, it was IVIS, and you said it was predominantly thrombus. So, a young person, you could have just kept him on DAPT for some time and come and rechecked if it had resolved. Of course, I mean, since there was no OCT, you wouldn't know if there is a little bit of underlying plaque there. But still, since it's thrombus, could we have waited?
Yes, actually, speaking, my impression mostly the thrombus on the left ventricle because of thrombus from anti-1 MI hypokinesia. But this is not recorded in the echo. First echo and second echo also, prior to the PCI also done. Some echocardiography also shows that some irregularity, not definite thrombus, he showed. So some irregularity will be perhaps maybe source site of the thrombus maybe. Very difficult.
I'm speaking of thrombus in the LAD, sir, not thrombus in the left ventricular cavity. Thrombus in the LAD. It's predominantly thrombus on IVIS. So why deploy a stent?
So though the thrombus is there, because patient is ongoing pain, that is the problem. We have to relieve the, we treat the pain, we relieve the obstruction. The persistent pain was there, in spite of this thrombolytic therapy. It is not cured. If it is my plan, if it is improved by thrombolytic therapy, we could have wait. Did not do anything. But patient ongoing pain is going on. It is persistent pain.
So before we conclude, just one question to you, sir.
Yes.
A great approach to actually thrombolyze this patient presenting with acute stroke as well as acute MI. Had the patient not improved neurologically, what would we have done? Which procedure would have been done first, the stroke or the MI intervention, or simultaneously as has been suggested by you, So it's, what are your thoughts on that?
I did give this some resource of the endotherapy, particularly endovascular, the radiologist or some neurologist there. That is ideally thrombus to be thrombectomy done first, followed by the angioplasty situation permit. So ideally to be done, but our centers that time system not available that moment. So thrombectomy done first from the brain.
Sir, regarding the choice of the imaging, do you think that if you have used an OCT, would have changed the management? Because it's a young patient, only thrombus, predominantly a thrombotic lesion, that too in the proximal LED, without any significant lesions or thrombus in any other coronary territories. If you have used an OCT imaging, whether it had showed a plaque erosion or something like that, and you would have avoided a stent in the young patient?
No, actually, still speaking, I thought this thing is OCT not available on my center, so that is the problem. Whether my plan to exclude the also SCAD also simultaneous. The SCAD, what has happened? There is a simultaneous dissection of the LED as well as the brain may happen, but we have excluded this thing. It is, my other study is not suggestive of any SCAD. OCT is not available in my center at that moment.
Thank you very much, sir. Thank you for this very interesting case.